Good day, everyone. Welcome to our case presentation regarding orbital cellulitis. Our discussion will revolve around the anatomy of the orbit, the case discussion, and of course, the disease, orbital cellulitis. Foremost, let's talk about the structure of the orbit. The superior margin is delineated by the frontal bone, whereas the lateral margin is presented with the processes of the frontal and zygomatic bones. The zygomatic bone and the maxilla compose the inferior margin, unlike the medial margin, which is comprised of the processes of the maxilla and the frontal bone. Structure of the orbit. The roof or the superior wall of the orbit separates the orbit from the anterior cranial fossa and the frontal lobe of the cerebral hemisphere. The largest contributor of the roof is the orbital part of the frontal bone, while the smallest posterior portion is completed by the lesser wing of the sphenoid bone. The only important landmark of this wall is the anterior laterally located depression called the lacrimal fossa, intended for hosting the orbital part of the lacrimal gland. Lateral wall is formed by the zygomatic bone anteriorly and the gradal wing of the sphenoid bone posteriorly. It is the thickest and the strongest wall of the orbit, which posteriorly separates the orbit from the middle cranial and temporal fossa. The most prominent landmark of the lateral wall is the superior orbital fissure, found between the greater and lesser wing of the sphenoid bone. The greater wing of the sphenoid bone also provides the lateral border of the inferior orbital fissure. The floor or inferior wall separates the orbit and the maxillary sinus. It is formed by three bones: maxilla, zygomatic bone, and the palatine bone. The orbital surface of the maxilla makes up most of it, while small portions of the zygomatic and palatine bones make up the rest. The most important landmark of the floor is the inferior orbital fissure. It separates the floor from the lateral wall and provides passage for the several neurovascular structures. It begins posteriorly and then courses along the lateral border of the floor. The part of the fissure that goes through the floor of the orbits is anteriorly bordered by the zygomatic bone, posteriorly by the orbital fissures of the palatine bone, and medially by the maxilla. The middle wall is built out of four bones: the maxilla, lacrimal bone, ethmoid bone, and the sphenoid bone. A useful mnemonic to remember them is "My little eye sits in the orbit." The majority of the wall is made out of the orbital plate of the ethmoid bone, which is located posterior-superiorly on the wall. This is the part of the ethmoid bone that contains ethmoidal cells and is very thin. Anterior to the ethmoid bone is the lacrimal bone, and anterior to the lacrimal bone is the frontal process of the maxilla. The lacrimal bone and the frontal processes of the maxilla build the lacrimal groove, which contains the lacrimal sac. Posterior to the ethmoid bone, the middle wall is completed by a small portion of the lesser wing of the sphenoid bone that forms the middle part of the optic foramen or canal. Besides the lacrimal groove, important landmarks are the anterior and posterior ethmoidal foramina and the trochlea. The ethmoidal foramina are found at the junction between the roof and the middle wall and as a part of the frontoethmoidal suture, and serve as the passageways for the anterior and posterior ethmoidal nerves and vessels. The trochlea is only the cartilage found in the orbit. It is a pulley-like structure in the orbit through which the tendon of the superior oblique muscle passes. Fun fact, the word trochlea comes from the Greek word for pulley. Now we proceed with the openings of the orbital cavity. First, orbital opening. This is the large anterior opening that forms the base of the orbit and communicates directly with the face. About 1/6 of the eyeball protrudes through the base and is exposed. The walls of the orbit protect the remainder. Second, supraorbital notch, often a supraorbital foramen. This is situated in the frontal bone on the superior orbital margin. It transmits the supraorbital nerve and blood vessels. The infraorbital groove and canal are situated on the floor of the orbit in the orbital plate of the maxilla. They transmit the infraorbital nerve, a continuation of the maxillary nerve, and blood vessels. Also, the nasolacrimal canal. This is located anteriorly on the middle wall in the lacrimal bone. It transmits the nasolacrimal duct and communicates with the inferior meatus of the nose. The anterior and posterior ethmoidal phenomena are two small openings on the middle wall, typically in the ethmoid bone. These transmit the anterior and posterior ethmoid nerves, both branches of the ophthalmic nerve respectively. The zygomatico-temporal and zygomatico-facial phenomena are two small openings on the lateral wall, usually in the zygomatic bone. These convey the zygomatico-temporal and zygomatico-facial nerves, both branches of the maxillary nerve respectively. The inferior orbital fissure is located posteriorly between the maxilla and the greater wing of the sphenoid. It communicates with the pterygopalatine fossa. It transmits the maxillary nerve and its infraorbital and zygomatic branches, the inferior ophthalmic vein, and the sympathetic nerves. The superior orbital fissure, which is located posteriorly between the greater and lesser wing of the sphenoid, communicates with the middle cranial fossa. It transmits oculomotor, trochlear, ophthalmic, and abducens nerves and the superior ophthalmic vein. Finally, the optic canal. This is located posteriorly in the lesser wing of the sphenoid at the apex of the orbit. It communicates with the middle cranial fossa, and it transmits the optic nerve and the ophthalmic artery. At this juncture, we talk about the orbital fascia. The orbital fascia is the periosteum of the bones that form the walls of the orbit. It is loosely attached to the bones and is continuous through the foramina and the fissures within the periosteum covering the outer surfaces of the bones. The extraocular muscles or the extrinsic muscles of the eyeball are involved in the movements of the eyeball or raising the upper lids. Foremost, levator palpebrae superioris. Its origin is under the surface of the lesser wing of the sphenoid, anterior superior to the optic canal. Its insertion is a flat muscle that widens as it passes forward above the superior rectus and ends anteriorly in the wide aponeurosis that splits into two lamella, superior and inferior. The superior lamella is inserted into the anterior surface of the superior tarsal plate, superior conjunctival fornix, and the skin of the upper eyelid. The inferior lamella, which contains smooth muscle fibers, is inserted to the upper margin of the superior tarsal plate. Its nerve supply is the superior lamella by the oculomotor nerve and the inferior lamella by the superior cervical sympathetic ganglion via the internal carotid plexus. Its action is to raise the upper eyelid. Second, recti muscles. We have four recti: superior, inferior, medial, and lateral. The origin of the four recti is arising from a fibrous ring called the common tendinous ring. It is a thickening of the periosteum, surrounds the optic canal and the middle part of the superior orbital fissure. Superior rectus arises from the upper part of the ring, the inferior rectus arises from the lower part of the ring, the middle rectus arises from the middle part of the ring, and the lateral rectus arises by two heads. One head from the lateral part of the ring, and the other from the greater wing of the sphenoid lateral to the ring. Between the two heads pass the oculomotor nerve, abducent nerve, and the nasociliary nerve. Insertion. The four recti pass forward. They become wider and separate from each other. Together they form a muscular cone that encloses the optic nerve and the posterior part of the eyeball. The tendon of each muscle pierces the fascial sheath of the eyeball and is inserted into the sclera about 6 mm behind the cornea. Nerve supply. Superior rectus, inferior rectus, and the middle rectus by the oculomotor nerve. The lateral rectus by the abducent nerve. The action is the lateral rectus for lateral rotation, the middle rectus for medial rotation, superior rectus for raising the eyeball upward. The inferior rectus is to depress the eyeball downward. Because inferior and superior recti are inserted on the middle side of the vertical axis of the eyeball, so they rotate the eyeball medially. Third, superior oblique. Its origin is from the body of the sphenoid, anterior medial to the optic canal. Insertion. Its rounded belly passes forward along the upper part of the medial wall of the orbit. Anteriorly, it ends in a slender tendon which enters the trochlea, a fibrocartilaginous pulley attached to the frontal bone. The tendon then turns posterolateral between the eyeball and the superior rectus to be inserted into the sclera behind the coronal equator of the eyeball. Nerve supply. Trochlear nerve is the nerve supply of this. For its action, it rotates the eyeball so the cornea looks downward and laterally. Fourth, inferior oblique. Its origin is the anterior part of the floor of the orbit. Its insertion, it passes backward and laterally below the inferior rectus. Then it curves upward to be inserted into the lateral side of the sclera, beneath the lateral rectus. Nerve supply. Oculomotor nerve. Its action is to rotate the eyeball so the cornea looks upward and laterally. Blood supply and lymph vessels. A rich network of ophthalmic blood vessels supply and drain the orbit. However, no lymph vessels or nodes are present in the orbital cavity. The ophthalmic artery is a branch of the internal carotid artery after that vessel emerges from the cavernous sinus. It enters the orbit through the optic canal with the optic nerve. It runs forward and crosses the optic nerve to reach the middle wall of the orbit. It gives off numerous branches that accompany the nerves in the orbital cavity. The ophthalmic artery forms a notable facial anastomosis with the angular artery, the terminal end of the facial artery, and the frontal branch of the superficial temporal artery. The central artery of the retina is a small branch that pierces the meningeal sheaths of the optic nerve to gain entrance to the nerves. It runs in the substance of the optic nerve and enters the eyeball at the center of the optic disc. Here, it divides into branches which may be studied in a patient through an ophthalmoscope. The central artery is the end artery to the retina. The muscular branches. The ciliary arteries supply the eyeball. They are divided into anterior and posterior groups. The former group enters the eyeball near the corneoscleral junction. The latter group enters near the optic nerve. The lacrimal artery to the lacrimal gland. The supratrochlear and supraorbital arteries are distributed to the skin of the forehead. Ophthalmic veins. The two main ophthalmic veins, superior and inferior, pass through the orbit. The superior ophthalmic veins form from the union of the supraorbital and supratrochlear veins draining the forehead. It communicates with the facial vein at the medial angle of the eye. The inferior ophthalmic vein communicates through the inferior orbital fissure with the pterygoid venous plexus. Both ophthalmic veins pass posteriorly through the superior orbital fissure and drain into the cavernous sinus. The superior ophthalmic vein originates around the superior medial orbital rim just posterior to the trochlea. It arises from the union of the two small branches of the facial and supraorbital veins. The former enters the orbit via the supraorbital notch, while the latter passes through the orbital septum. The superior ophthalmic vein takes a posterior course between the superior rectus muscle and the optic nerve, cranial nerve 2, traveling close to the ophthalmic artery. It traverses the recto-orbital fat and leaves the orbit through the upper part of the superior orbital fissure, just above the lateral rectus muscle. Ultimately, the superior ophthalmic vein opens into the cavernous sinus. On its way through the orbit, the superior ophthalmic vein receives the following tributaries: anterior and posterior ciliary veins, the two superior two vorticose veins, vortex veins from the upper half of the eye, episcleral veins from the eyelids and conjunctiva, the central retinal vein, the lacrimal vein, the nasofrontal vein, anterior and posterior ethmoidal veins. The inferior ophthalmic vein originates from the posterior end of an inferior ophthalmic venous plexus located on the anterior part of the floor of the orbit. The vein runs posteriorly, passing under the eyeball and over the surface of the inferior rectus muscle. The inferior ophthalmic vein courses through the superior orbital fissure, just below the common tendinous ring or the annulus of Zinn. It either drains directly into the cavernous sinus or into the superior ophthalmic vein. The inferior ophthalmic vein receives the following tributaries within the orbit: muscular branches from the inferior rectus and inferior oblique muscles, the two inferior vorticose veins from the lower half of the eyeball, a communicating branch with the pterygoid venous plexus via the inferior orbital fissure. Eyelids, conjunctiva, and lacrimal apparatus. In cross-section from outside inside are skin, Orbicularis oculi, or the sphincter muscle, fibrous tarsal plates, conjunctiva. These is no subcutaneous fat dipped to the skin of the eyelids. Skin is devoid of hair except at eyelashes. Tarsal plates act to stiffen the eyelids. Inferior tarsus is attached to the lower orbital margin. Superior tarsal plate is larger. Conjunctiva is adherent to the dipped surface of the tarsal plates. Palpebral fascia forms an orbital septum, which attaches each tarsal plate to the orbital margin. The tendon of the levator palpebra superioris enters the eyelid and attaches to the tarsal plates in the orbicularis oculi. The levator palpebra superioris is supplied by both voluntary and involuntary fibers. The voluntary fiber is by the oculomotor nerve, or cranial nerve 3, and involuntary by the sympathetic neurons. The contraction of the levator palpebrae superioris will raise the upper eyelid. The eyelid can only be raised properly if both the voluntary and involuntary parts of the muscles are functioning. The glands of the eyelid includes the ciliary glands and the tarsal glands. The former is directly behind the roots of the eyelashes, and when infected, will cause a red swelling or so-called dystye. The tarsal glands are vertical rows on the dipped surface of the tarsal plates, and its ducts open onto the lid margin. The nerve supply of the upper eyelid is the ophthalmic division of trigeminal nerve. The nerve supply of the lower lid is the infraorbital nerve, a branch of the maxillary division of the trigeminal nerve. The branches of the ophthalmic nerve of the trigeminal to the orbital region include palpebral branch of lacrimal, supraorbital, supratrochlear, and infratrochlear. The conjunctiva lines deep surface of the eyelid and exposed surface of the eye. It continues with the anterior epithelium of the cornea. The fornices are the recesses of the conjunctiva above and below where the palpebral port reflects onto the eyeball, whereas the palpebral fissure is an elliptical space between the two eyelids. The lacrimal gland lies mainly in the orbit. It does have a small palpebral port which extends into the upper eyelid. The secretion of the tears by the lacrimal gland is initiated by parasympathetic fibers. The eyeball. The eyeball consists of 3 coats or layers. From external to internal, these are the external fibrous coat, the middle vascular coat, and the inner nervous coat. The eyeball contains 3 major supportive or refractive media: the aqueous humor, the vitreous body, and the lens. The external protective fibrous coat is made up of posterior opaque part, the sclera, and an anterior transparent part, the cornea. The opaque sclera is composed of dense fibrous tissue and is white. The optic nerve pierces the sclera posteriorly, and the nerve's dural sheath fuses with the sclera. The cornea. The transparent cornea is largely responsible for the refraction of light entering the eye and is the most important refractive medium of the eye. The cornea is avascular and devoid of lymphatic drainage. It is nourished by diffusion from the aqueous humor and from the capillaries at its edge. The nerve supply is the long ciliary nerves from the ophthalmic division of the trigeminal nerve. The middle vascular pigmented coat consists from behind forward of the choroid, the ciliary body, and the iris. The choroid is composed of an outer pigmented layer and an inner, highly vascular layer. The ciliary muscle is composed of meridional and circular fibers of smooth muscle. The meridional fibers run backward from the region of the corneoscleral junction to the ciliary processes. The circular fibers are fewer in number and lie internal to the meridional fibers. The ciliary muscle is supplied by the parasympathetic fibers from the oculomotor nerve. After synapsing in the ciliary ganglion, the postganglionic fibers pass forward to the eyeball in the short ciliary nerves. Contraction of the ciliary muscle, especially the meridional fibers, pulls the ciliary body forward. This relieves the tension in the suspensory ligaments, and the elastic lens becomes more convex. This increases the refractive power of the lens. The iris is a thin, contractile, pigmented diaphragm with a central aperture, the pupil. It is suspended in the aqueous humor between the cornea and the lens. The periphery of the iris is attached to the anterior surface of the ciliary body. It divides the space between the lens and the cornea into an anterior and a posterior chamber. The sphincter pupillae is supplied by the parasympathetic fibers from the oculomotor nerve. After synapting in the ciliary ganglion, the postganglionic fibers pass forward to the eyeball in the short ciliary nerves. The dilator pupilla is supplied by the sympathetic fibers, which pass forward to the eyeball in the long ciliary nerves. The sphincter pupilla constricts the pupil in the presence of bright light and during accommodation. The dilator pupilla dilates the pupil in the presence of light of low intensity or in the presence of excessive sympathetic activity such as occurs in flights. The inner nervous coat consists of the retina. The retina consists of an outer pigmented layer and an inner nervous layer. Its outer surface is in contact with the choroid, and its inner surface is in contact with the vitreous body. The posterior three-quarters of the retina is the receptor organ. Its anterior edge forms a wavy ring, the ora serrata, where the nervous tissues end. The anterior part of the retina is non-receptive and consists of pigmented cells, with a deeper layer of columnar epithelium. This anterior part of the retina covers the ciliary processes and the back of the iris. At the center of the posterior part of the retina is an oval yellowish area, the macula lutea, which is the area of the retina for the most distinct vision. It has a central depression, the fovea centralis. The optic nerve leaves the retina about 3 mm to the middle side of the macula lutea by the optic disc. The optic disc is slightly depressed at the center, where the central artery of the retina pierces it. There is a complete absence of rods and cones at the optic disc, so that it is insensitive to light and is referred to as the blind spot. On ophthalmoscopic examination, the optic disc appears pale pink in color, much paler than the surrounding retina. Sinus anatomy. The orbit has a close anatomical relationship to the paranasal sinuses. It has 4: the optic canal on the sphenoid. On the roof is the frontal, medial for ethmoid, and the floor is maxillary. The ethmoid sinuses are composed of 3 to 18 pairs of air cells within the ethmoid labyrinth and can be divided into anterior, middle, and posterior ethmoid cells with distinct drainage locations in the nasal cavity. These thin-walled cavities can invade the other paranasal sinuses. The relations to surrounding structures are as follows. In the superior is the anterior cranial fossa, frontal bone, and sinus. On the middle is the nasal cavity, and on the lateral is the orbit. Clinical significance. The ethmoid sinus has several anatomical variants. The Reymond-Gie cell is also known as the sphenoethmoidal air cell. The mucocele in this structure can compress the optic nerve, causing an acute retrobulbar optic neuropathy. The lamina papyracea forms the middle wall of the orbit. This is a thin, bony structure that has important clinical relevance. In pediatric patients, paranasal sinusitis is most often involving the ethmoid sinus, and it can spread through the thin lamina papyracea of the middle orbit wall into the orbit, resulting in a cellulitis of the orbital area. Furthermore, damage to the lamina papyracea is a potential complication of endoscopic sinus surgery. This can lead to permanent ocular motility disorder and visual impairment due to its proximity to the extraocular muscles and optic nerve. The frontal sinuses are a pair of typically asymmetric and triangular air cavities separated by the frontal septum. Relations to the surrounding structures are as follows. On the superior is the anterior cranial fossa, inferior is the orbit, anterior ethmoidal sinuses, and nasal cavity. On the anterior are the forehead and superciliary arches. In the posterior are the anterior cranial fossa, and in the middle is the other frontal sinus. The sphenoid sinuses are the most posterior paranasal sinuses. They are of irregular shape and are asymmetric due to the irregular septum. Relations to the surrounding structures are as follows. On the superior is the hypophyseal fossa, together with the pituitary gland and optic chiasm. On the medial side are other sphenoid sinuses. On the lateral are cavernous sinus, internal carotid artery, and cranial nerves 3, 4, V1, V2, and 6, but on the anterior are the nasal cavity. The sphenoid sinus is in close relationship with the optic canal. In fact, the optic canal is located superior and lateral to the sinus wall. Sinusitis within the sphenoid sinus in the posterior cell of the ethmoid sinus can thus compress the optic nerve, causing an acute retrobulbar optic neuropathy. The maxillary sinuses are the greatest in size of all the paranasal sinuses. They have thin, bony walls and are shaped like pyramids, whose base is the lateral wall of the nasal cavity and the apex toward the zygomatic process of the maxilla. Relations to the surrounding structures are as follows. On the anterior medial part is the nasolacrimal duct. Superiorly are the orbit, infraorbital nerve, and the vessels. Inferior would be the roots of molars and premolars. On the middle are the nasal cavity, and on the lateral and anterior are the cheek. Posteriorly are the infratemporal fossa and the pterygopalatine fossa. The roof of sinus forms floor of the orbit. The infraorbital neurovascular bundle travels along the roof of the sinus. Therefore, an orbital floor fracture can damage the infraorbital nerve, resulting in paresthesia or numbness of the infraorbital distribution. The bone is thinner medial to the infraorbital canal, therefore blowout fractures usually involve the medial part of the orbital floor. Silent sinus syndrome is associated with asymptomatic chronic maxillary sinusitis. It is initiated by an impaired outflow through the osteomyelial complex. This obstruction results in the chronic fluid accumulation, resorption, and thus negative pressure in the maxillary sinus. The final pathogenesis pathway leads to the maxillary sinus atelectasis and collapse of orbital floor. Clinical manifestations include unilateral enophthalmostosis, hypoglobus, and vertical diplopia. That now concludes the anatomy area of this discussion. Let's proceed with the meaty part, which is the case discussion per se. This is a case of patient MR, a 50-year-old male who hailed from Barangay La Union, is born on October 4, 1973, married, Roman Catholic, and works as a farmer. The patient came in with a chief complaint of toothache and a bulging left eye. With regard to the history of present illness, everything started 7 days prior to admission, whereby the patient started experiencing toothache with no other associated signs and symptoms, no medications taken, and no consultation done. The patient in this time just resumed with his daily activities over the next 2 days. Meanwhile, 4 days PTA, the patient had a headache as well. He took Alaxan Forte twice and self-medicated with amoxicillin, however it afforded no relief. Subsequently, 3 days PTA, with the exacerbation of the signs and symptoms, the patient was admitted to Cabad District Hospital, where he was managed with ceftriaxone and metronidazole and was sent home. 2 days PTA, the patient has still toothache and headache. He also noted periorbital swelling with associated tenderness and lacrimation. This prompted consultation at Cabad District Hospital, where he was admitted for 2 days until he was referred to our institution for further evaluation and management. In regard to the patient's past medical history, the patient is a known case of uncontrolled hypertension and diabetes mellitus, having non-compliant to medications of losartan and metformin respectively. The family history of the patient revealed hypertension and prostate cancer on the maternal and paternal side in that order. The personal and social history of the patient revealed non-smoking, but occasionally drinks alcohol of 1 to 2 shot glasses of gin. He denies any illicit drug use, and the patient is a farmer. The review of systems revealed generally undocumented fever and body weakness. HEENT noted of headache, dizziness, tearing, and redness together with eye discharge. Now, on physical exam, these are the photos taken during the admission. The visual acuity exam revealed that there is 20/20 vision on the right eye, however, negative hand motion with good light projection on the left. There were also noted axial proptosis, chemotic hyperemic conjunction, and clear cornea with deep anterior chamber. Several differentials can be noted on this particular case. Foremost is periorbital cellulitis. This is the inflammation and infection of the eyelid skin and soft tissue anterior to the septum. The eyelid becomes edematous, erythematous, and inflamed. However, there is no globe involvement, no ocular pain, and mobility impairment chemosis. Hence, this is ruled out. This slide projects the comparison between preseptal or periorbital and the orbital cellulitis. Orbital cellulitis should be suspected in any patient with adnexal, facial, or dental infection when orbital pain, proptosis, limitation of ocular motility, lid edema, or orbital congestion develop. A computed tomography scan should be obtained, and the patient should be hospitalized and placed on broad-spectrum intravenous antibiotic therapy as deemed appropriate. Orbital cellulitis resulting from sinusitis usually can be distinguished easily from other causes of acute inflammatory proptosis by clinical signs and CT scanning and the assessment of risk factors. Another diagnosis would be orbital pseudotumor, which is a diagnosis of exclusion. This is a common presentation of proptosis. Usually, it occurs with motor deficit, pain, lid swelling or lid mass, ptosis, and chemosis. The last differential is thyroid eye disease or the Graves' orbitopathy. Thyroid-associated orbitopathy usually has a more subacute course than orbital cellulitis, with characteristic features such as lid retraction and preferential involvement of the inferior recti and medial recti, typically with tendon sparing. Having noted of the clinical signs and symptoms together with the result of the CT scan, our final diagnosis is orbital cellulitis, left eye. The plan of medications for our patient are as follows. The patient is noted for the following: losartan, hydrocortisone, timolol, tobramycin plus dexamethasone eye ointment, metformin, atorvastatin, amlodipine, chlorhexidine, paracetamol, human insulin isophane, 12 and 6 units for that, sodium chloride nasal spray, cefepime, metronidazole, and celecoxib. With regard to the course in the wards, on day 1, the patient was admitted to the off-the ward with PNSS on KVO and maintained on NPO for OR purposes and on low salt, low fat diet together with DM diet. There were also diagnostics noted here with treatments to include clindamycin, celecoxib, and ceftriaxone. The patient was also noted to be referred to IM GenMed, IM IDS, Dental, ENT for evaluation and co-management. Also, the patient was observed for proper oral and body hygiene. On the same day, having noted of swollen tender left eye with purulent discharge by the IM GenMed with a diagnosis of odontogenic orbital cellulitis, the patient was maintained on DM and low salt, low fat diet with a diagnostic of blood culture in 2 sites. Also, there was a discontinuation of ceftriaxone but to start Ampisol on a Q4 basis. Also, CBG was monitored together with losartan given on this time. There were also anti-DM medications given once FBS and HbA1c were extracted. Hypoglycemic protocol were also initiated at this moment, and there was a support to do orbital CT scan care of the main service, which is OFTA, and to start paracetamol Q4 for fever. On the same date, ORL noted acute bacterial rhinogingivitis, in which they agreed with clindamycin ampisolbactam that added sodium chloride nasal spray. Also, there was a note for panendoscopy on the 26th in a suggestion of referral to dental for possible tooth extraction. On the second day, the main service added timolol brimonidine eye drop and tobramycin dexamethasone eye ointment for the medications. On that exact second day of admission, IM GenMed noted 3 major problems. Specifically for hypertension, they continued losartan and amlodipine, and they noted of for the diabetes to start metformin, atorvastatin, and to facilitate referral to endo. But for the febrile episodes of the patient, they increased the paracetamol to 600 milligrams, to use called PNSS 1 liter every 16 hours as IVF, to do TSB care of the watcher, and to continue antibiotics with the oral care of chlorhexidine gargle OD. IM Endo on the second day came and noted to add human insulin isophane 12 units in AM and human insulin isophane 6 units in PM. CBG monitoring was also initiated 3 times pre-meals and at bedtime with a hypoglycemic protocol on the side. On the 26th of March, off the service noted to continue present management. On the day 3, IMIDS discontinued Ampisol and clindamycin and to start piperacillin and tazobactam, 4.5 grams IV Q6 together with vancomycin. Also, they suggested referring back to ENT for possible surgical interventions. On the third day, IM GenMed also increased losartan and amlodipine to 110 milligrams respectively. IMIDS noted continuing present management, whereas ORL suggested to start hydrocortisone 200 milligrams TIV now, then 100 milligrams Q6 times 3 doses. On the 27th, off the service initiated referring back to IDS for the initiation of steroid therapy, whereby IMIDS noted for repeat CBC and procalcitonin for that particular day. Dental service also came noting of panoramic radiographic request for further evaluation on tooth concern and for GenMed IM clearance prior to multiple extraction and refer once there is panoramic result. The next day on the 28th, off the service noted of starting celecoxib and for referral to IM GenMed for CP clearance on the planned dental procedure and is scheduled for panoramic radiography in the morning. IMIDS also came that day, shifting pipertazo to cefepime and continuing vancomycin. There were also diagnostics to include CBC, procal, and creatinine on that day, suggesting drainage of the abscess and to follow up culture, and for blood CS in 2 sites if not yet done, together with starting metronidazole 500 mg IV every 8 hours. IM GenMed came on that same day, noting of the contemplated procedure of multiple dental extraction and was advised to have ECG, sodium and potassium, and referring back once with the results for risk stratification. On the 4th day of admission, the patient was noted to have an IM GenMed notes of discontinuing amlodipine but continuing losartan. The risk stratification is at low to undergo contemplated procedure of multiple tooth extraction with a note of maintaining adequate hydration during the process or procedure. ORL also note of still for penendoscopy, with now OFTA and IMIDS planning to start prednisolone 1 mg per kilogram and to continue antibiotics. OFTA also noted to start the following medications: paracetamol plus tramadol, paracetamol 600 mg through IV PRN for temp of more than 37.8, prednisone 20 mg per tub, and omeprazole 40 mg per capsule. As of date, the patient is still due for tooth extraction. Proceeding now to the diagnostics that the patient had undergone. The patient's X-ray revealed unremarkable findings. For the complete blood count with platelet of the patients extracted from March 24, 27th, and the 29th, there was a noted increase in hematocrit, WBC, and monocyte together with the platelet count, but there is a decreasing trend for the RBC, hemoglobin, lymphocytes, eosinophils, and MCV of this particular patient. With regard to the electrolytes of the patient, there was a low chloride and magnesium of 95.5 and 0.74 respectively, and a consistent low sodium of 131.6 and 131.8 on the 24th and 28th extractions. Some other blood chemistries were also drawn, revealing HbA1c of 9, procal of 0.5 going 0.59 from 24 to 29, and a blood glucose FBS of 10.21, but relatively low HDL and LDL of 0.80 and 2.03 respectively. The panoramic X-ray of the patient revealed adhesions of the incisor and occlusion of number 24. Also, there was a positive interproximal calcular deposits on the marginal gingivitis lingual, with other 0 noted, and moderate calcular deposits or lingual or mandibular anterior teeth with gingival excision, but negative tissue lesion noted. Meanwhile, the CT scan noted a hyperdensity on the cavernous sinus. At this moment, let us discuss orbital cellulitis. Orbital cellulitis and preseptal cellulitis are the major infections of the ocular adnexal and orbital tissues. Orbital cellulitis is an infection of the soft tissues of the orbit posterior to the orbital septum, and preseptal cellulitis is an infection of the soft tissue of the eyelids and preocular region anterior to the septum. Orbital cellulitis and preseptal cellulitis can sometimes be a continuum. Orbital cellulitis has various causes and may be associated with serious complications. As many as 11% of cases of orbital cellulitis result in visual loss. Prompt diagnosis and proper management are essential for curing the patient with orbital cellulitis. Orbital cellulitis is commonly associated with sinus infection and can be caused by direct extension of infection from the globe, eyelids, ocular adnexa, and other periocular tissues. Orbital cellulitis may follow dacrocystitis, osteomyelitis of the orbital bones, phlebitis of the facial veins, and dental infections. Orbital cellulitis resulting from infection of the maxillary sinus, secondary to dental infections, can be caused by microorganisms indigenous to the mouth, including anaerobes, commonly Bacteroides species. Infectious material may be introduced into the orbit directly through accidental, for example, orbital fracture or surgical trauma. Indeed, orbital cellulitis may be caused by any injury perforating the orbital septum. Orbital inflammation may be noted within 48 to 72 hours after injury, or in the case of a retained orbital foreign body, it may be delayed for several months. Streptococcus species, specifically Streptococcus aureus and Haemophilus influenza type B, are the most common bacterial causes of orbital cellulitis. Pseudomonas, Klebsiella, and Enterococcus are less common culprits. Polymicrobial infections with aerobic and anaerobic bacteria are more common in patients aged 16 years old or older. Fungal causes of orbital cellulitis are commonly mucor and aspergillus species. Fungi can enter the orbit. Orbital cellulitis due to fungal infections carries a high mortality rate in patients who are immunosuppressed. Pathway of infection. The middle orbital wall is thin and is perforated by numerous valveless blood vessels and nerves, as well as by numerous defects in the lamina papyracea, Zucker-Kendall dehiscences. This combination of thin bone, foramina for neurovascular passages, and naturally occurring defects in the bone allows for easy communication of infectious material between the ethmoidal air cells and the subperiorbital space in the middle aspect of the orbit. The most common location of a subperiorbital abscess is along the middle orbital wall. The periorbital is adherent relatively loosely to the bone of the middle orbital wall, which allows abscess material to easily move laterally, superiorly, and inferiorly within the subperiosteal space. In addition, the lateral extensions of the sheaths of the extraocular muscles, the intermuscular septa, extend one rectus muscle to the next, and from the insertions of the muscles to their origins at the annulus of Zinn posteriorly. Posteriorly in the orbit, the fascia between the rectus muscles is thin and often incomplete, allowing easy extension between the extraconal and intraconal orbital spaces. Venous drainage from the middle third of the face, including the paranasal sinuses, mainly is via the orbital veins, which are without valves, allowing the passage of infection anterograde and retrograde. Epidemiology. An increased incidence of orbital cellulitis occurs in the winter nationally and internationally because of the increased incidence of sinusitis in cold weather. In the US, an increase has been noted in the frequency of orbital cellulitis owing to community-acquired methicillin-resistant Staph aureus infections. In children, orbital cellulitis has been reported as twice as common in males as in females. In adults, however, no difference in the frequency of orbital cellulitis exists between the sexes, except for cases caused by MRSA, which are more common in females than in males by a ratio of 4:1. Orbital cellulitis in general is more common in children than in adults. The median age range of children hospitalized with orbital cellulitis is 7 to 12 years old. Clinical findings. A thorough history and physical exam are critical in establishing a diagnosis of orbital cellulitis. Patients with orbital cellulitis frequently complain of fever, malaise, and a history of recent sinusitis or upper respiratory tract infection. Questioning the patient about any recent facial trauma or surgery, dental work, or infection elsewhere in the body is important. Diverse conditions such as sickle cell orbitopathy, biphosphonate use, and cosmetic fillers can cause orbital inflammation that can be mistaken for infection. Proptosis and ophthalmoplegia are the cardinal signs of orbital cellulitis. The symptoms and signs of orbital cellulitis can advance at an alarming rate and eventually lead to prostration. Causative agents. Pathogens vary by etiology and patient age. Streptococcus pneumoniae is the most frequent pathogen associated with sinus infection, whereas Staphylococcus aureus and Streptococcus pyogenes predominate when infection arises from local trauma. Haemophilus influenza type B, once a common cause, is now less common because of widespread vaccination. Fungi are uncommon pathogens causing orbital cellulitis in patients who have diabetes or in those who are immunosuppressed. Diagnostic considerations. The diagnosis of orbital cellulitis is primarily clinical. If findings are equivocal, if the examination is difficult, as in young children, or if nasal discharge is present suggesting sinusitis, CT or MRI should be done to exclude orbital cellulitis, tumor, and pseudotumor. MRI is better than CT if cavernous sinus thrombosis is being considered. On complete blood cell count, there is leukocytosis, which is greater than 15,000 with a shift to the left commonly seen. On blood cultures, obtain blood cultures prior to the administration of any antibiotics, although they are unlikely to reveal the responsible organism. Purulent material assessment. Collect purulent material from the nose with a cotton or calcium alginate swab, smear for gram stain, and culture on aerobic and anaerobic media. Assess any material obtained from the sinuses or directly from an orbital abscess in the same manner. Treatment. Approach considerations are as follows. The patient with orbital cellulitis should be promptly hospitalized for treatment, with hospitalization continuing until the patient is afebrile and has clearly improved clinically. Historically, the presence of subperiosteal or intraorbital antibiotic therapy. Antibiotic therapy with second to third generation cephalosporin. If anaerobic pathogen is suspected, usually caused by dental infection, metronidazole is used. Canthotomy and cantholysis should be performed on an emergency basis if an orbital compartment syndrome is diagnosed. In patients with corneal exposure, continued lubrication is important. One may fashion a moisture chamber from lubricant ointment and a saran wrap in cases of poor lid closure. Consider surgical drainage if the response to appropriate antibiotic therapy has been poor within 24 to 48 hours. If the CT scan shows the sinuses to be completely opacified, if the patient has an intraorbital abscess, or if there is a large subperiosteal abscess, especially in an adult. The drains should be left in place for several days. Repeat surgical drainage may be required. In cases of fungal infection, surgical debridement of the orbit is indicated and may require exenteration of the orbit and the sinuses. And that is the end of our presentation. Thank you so much for listening, and we hope that you've learned a bit from our discussion. Thank you so much. Have a blessed day.